Late-stage HD is defined as the end stages of HD. Often when these patients reach this stage, they're going to have difficulty caring for themselves for their basic needs. Most of these patients in end stage or late-stage HD are going to be in long-term care facilities or be requiring kind of round-the-clock care. They've lost their abilities to do basic things like hygiene, and feeding, dressing, those kinds of things. So because of that, these patients, obviously when you reach the late stages, will require more resources, a lot more considerations around end-of-life care and palliative care and those kinds of things that will need to be brought in. There are a lot of important considerations, though, in late-stage HD. Even though physically they cannot respond, or physically there are a lot of things that they can't do, and they may have the dementia that often comes with Huntington's disease, it doesn't mean that they can't understand what's going on around them. So that's a really important thing that we try to drive home, is just because they can't physically respond doesn't mean that they're not understanding what is happening in the world around them, at least to some degree. So we encourage caregivers, staff, support staff, or people around our patients, even late-stage HD, to talk to the patient, engage them. Don't act like there's nobody in the room kind of thing, because they often can interpret at least some of what's going on. There are safety considerations that are important in patients with late-stage HD. Due to the movement disorder aspect of it, one of the common things that I talk about is, if they have these abnormal involuntary movements, the chorea or other movements, if they're in a long-term care facility, things that sometimes people don't think about are the cords that commonly accompany, like the TV remote or the nurse call button, things like that. Avoiding really long cords nearby the patient where they can kind of become entangled in them. I think that's an important safety measure. And just thinking about, there are many things in late-stage HD outside of pharmacologic treatments that can really help to improve the patient's quality of life. So that's probably my big mantra for late-stage HD care, is pharmacologic but also non-pharmacologic treatment options, and kind of thinking outside of the box, if you will. You can pad the patient, you can pad the room. I've had HD patients in facilities where they'll use those foam interlocking block pad things that are often used for toddlers for play, and use those to line the floor or to line the walls. Those are relatively inexpensive and can keep a patient safe, and don't say hospital all over them. They're usually fun colors and things like that. Communication is often difficult for our patients with HD. Their speech becomes slurred from the physical impairments of Huntington's disease, and the cognitive parts, they may be delayed in getting the words out, things like that. So communication can be a challenge. Understanding what the patient needs can be a challenge. So using things like communication boards, they have apps that you can download on iPads or phones where the patient can point at things and it will speak the word out loud, or can point at things that they're wanting to say or wanting to communicate. But you can even go as low-tech as there are many communication boards that you can find on Google. In the image section, you just Google communication boards, and you can print that out on a piece of paper and put that on a card or something for the patient, and they can similarly point to things to get across. And then simple adaptations for swallowing. Swallowing is certainly a big issue in late-stage HD, but you don't want to take away the pleasure of eating. If they enjoy things that normally are fairly indulgent, like ice cream and things like that, you can still do ice cream and milkshakes and things like that, because many times in late-stage HD you have weight loss. So in my HD patients, I don't worry about calories and being on a diet and things like that. So I encourage them, if they like it, eat it, let them have it. If they can eat it safely, and trying to navigate other ways around it so they can eat it safely, using cups with lids, using different kinds of swallowing techniques to help them to swallow safely, things like that. There are ways to work around and be creative. I had a patient who he loved Mountain Dew, but he had a swallowing problem with liquids, and when you put that thicket powder stuff to thicken the liquids into any carbonated beverage, it will take out all the carbonation and make it really taste disgusting. And so he was really bummed about that. His favorite thing in the world was Mountain Dew, and he couldn't have this anymore. So our speech therapist came up with, oh, well, you can just make a slushie out of it. Just blend ice and put Mountain Dew in it, and the blended ice will give enough texture that he can swallow it safely, and it won't take out the carbonation, and he can still enjoy the flavor and taste of the Mountain Dew. So small things like that, being willing to think outside the box and really help these patients in the late stages. Behavioral issues in the late stage can often be an issue, and sometimes it's as simple as when the patient's sleep-wake cycle gets off. It often comes out as unwanted behaviors, but if the patient is staying up all night and then sleeping all day, that goes against the rigorous type of schedule that they often want to keep in a long-term care facility, and that can promote kind of behavioral issues. If they've been up all night and they want to sleep all day, but they have these activities that they're supposed to participate in, and they try to force the patient to get up, that they may meet some resistance, things like that. So the simple things to maintain the sleep-wake cycle, if the sleep-wake cycle has gotten really far off and day and night are completely flip-flopped, I often recommend trying to scale back just an hour or two at a time, a week at a time. Move if they're staying up all night, well, try to have them go to bed at 2 a.m. for a week, and then try to have them go to bed at midnight for a week, and then 10 p.m. for a week or something like that, and slowly slide it back and see if you can help with the sleep-wake cycle, things like that. So if you need to, you can use pharmacologic interventions to really help to sedate. I try to avoid using both sedatives and stimulants at the same time because I think you're fighting both things, but sometimes you need to do one or the other to really help to re-regulate sleep-wake cycle, but then have a low threshold once it's re-regulated to try to pull back some of those medication options so it can be as natural as possible.